Good evening, everyone. Thanks for joining us in our discussion tonight on chronic hepatitis B. My name is Scott Springer. I'm a physician assistant. I live and work in Buffalo, New York at Erie County Medical Center, an outpatient hepatology clinic. And I'm joined by my colleague and friend, Dawn.
Hi, I'm Dawn Drazek. I'm a nurse practitioner with Atrium Liver Care in North Carolina.
So yeah, like I said, thanks for joining us tonight. Pretty much the goal of this is to go over some of the different guidelines that we utilize in clinical practice for initiating patients on chronic hepatitis B treatment. So we're going to discuss that a little bit, as well as discussing some treatment considerations for more unique populations of patients that might have chronic hepatitis B infections. What do we have to do about it? What do the guidelines say? What do we actually do in clinical practice? So maybe to get started, Dawn, would you go over for us what the 2018, which are the most updated AASLD guidelines, tell us as far as initiating treatment in these patients?
So the other thing we definitely is how do we then put these guidelines into practice with our unique populations and just patients with Hep B in general. And when we look at Hep B guidelines, often we think of the AASLD guidelines, but there's also EASL guidelines and AAPSL guidelines and AATA guidelines. So for most of us that work in hepatology, AASLD is our go-to. With AASLD guidelines, there's a lot of things that we check. We want to know their hepatitis B E antigen status, what their viral load is, what their ALT is. Now, somebody has, if they're E antigen positive with a viral load over 20,000 and elevated ALT, that's when we would start those patients on treatment. And if they're E antigen negative with a viral load over 2,000 and an elevated ALT, then you start those patients. And both those patient groups would be considered what we often think of as immune active, meaning that the immune system is mounting a response to the virus being there. And the other thing we also want to look at in the population is, do they have cirrhosis? What is their status that way? Because those patients that are cirrhotic, you want to start them on treatment regardless of their ALT if they have detectable virus.
Yeah. So, I mean, I think one point that you bring up there that I think a lot of people in clinical practice have difficulty with is there's a lot of different parameters. There's a lot of different kind of criteria or data points that we're looking at initiating treatment for these patients. For example, in the AASLD guidelines, they talk about, is the hepatitis B DNA level over 2,000 in some patients, is it over 20,000 in some other patients? So naturally what happens, at least I find in my practice, is a lot of times the patient doesn't kind of neatly fit in one of the boxes, right? So one thing that Dawn and I have discussed and we're seeing more in clinical practice is a push towards a more streamlined, simplified approach to initiating treatment in these patients. Kind of similar to what's going on in the hepatitis C world, where we're trying to initiate any patient who's viremic, essentially, on direct-acting antiviral therapy. There's evidence based to support a similar approach in patients with chronic hepatitis B. So oftentimes when you have these patients that are in kind of the gray area, maybe their ALT is at a certain level, but their DNA isn't. Have they seroconverted their BE antigen to antibody? So these simplified guidelines can be helpful, especially for newer clinicians engaging in patients with chronic hepatitis B. And always an important part of managing patients with chronic hepatitis B is having them be a part of the decision-making process as well. What's going to work best for them? What are they comfortable with? And especially when we're talking about, unique populations, for example, like patients who are pregnant, patients who have chronic kidney disease, more advanced liver disease, with fibrosis, potentially cirrhosis or decompensated cirrhosis, which certainly introduces some novel challenges and makes it that much more important to get the patient's buy-in to what we are doing.
And you bring up a really good point with working with our patients to make decisions. A lot of times, patient populations with hepatitis B, English may not be their first language. So when you're working with somebody and trying to explain with an interpreter, no less, that, yes, you have this disease, but we're not going to treat it right now, can be a challenging thing for those patients to really grasp onto. And then if we're telling somebody, we're not going to treat this right now, sometimes that comes across as then you don't need long-term follow-up, which then falls into, long-term management of these patients as far as when to start screening for liver cancer, following long-term, making sure that they're getting labs periodically to determine when and if to start treatment.
Yeah, absolutely. And one other piece of this that, that is talked about, but maybe not fully understood is like what exactly is immune active versus immune tolerant. Because it can be kind of confusing. This frankly isn't terminology that I use often in my clinical practice, but it does play, it is used in the literature. And when you're looking at the treatment guidelines, you kind of want to understand, like Dawn mentioned earlier, like which parameters indicate one versus the other. So essentially, I think the easiest way to kind of understand it is the hepatitis B itself isn't damaging to the liver. Your body's immune system in fighting the hepatitis B virus is what's damaging to the liver. So when you're in the immune active phase, it means your immune system is actively working to fight off the hepatitis B virus. And because of that, that's where you're seeing these increased ALT levels. And that's essentially what leads to the fibrosis and why those patients in the immune active phase are the ones who need treatment, as opposed to patients who are in the immune tolerant phase. They might have, viremia with quantifiable levels of HBV DNA. However, if your body isn't fighting it off and damaging the hepatocytes, they may not need treatment. So, that's where the understanding of the immunology in this is really important, and explaining that to patients like Dawn, you just said, because it can be really confusing. You're telling me I have this chronic disease that could lead to liver cancer, death, but you're not starting me on treatment. So, I mean, that conversation also can be really beneficial to the patient as well as other providers that you might be working with, because I know Dawn and I were talking about this earlier. We, understanding of even something as seemingly basic as hepatitis B serologies is challenging for a lot of providers. Never mind a complicated disease process like chronic hepatitis B.
And it's interesting, the simplified recommendations that came out. There was a study done that looked at 84,000 patients and whether or not they met the criteria in the various guidelines. And even those that did not meet criteria for treatment, about 10% of them had advanced fibrosis. So it begs the question of, even when there's low level viremia going on there, are we missing kind of that viremia in between when they're being watched or when we're checking labs? And if we want to see hepatitis B be eradicated, then I think like we're seeing with hep C now, we need to look beyond just GI and hepatology to some degree for patients that don't have good access. And if we make it very simple where there's viremia, you put these patients on med, that we may be able to achieve that. And I think in the study, it was something like 84% of patients would have met criteria if we simplified it down. It is simple as, yes, there's detectable virus, start them on treatment.
Yeah, absolutely. So the next thing we have on our list here is discussing, first line treatments for hepatitis B infection. But to kind of preempt that, I think the important and another really important thing to talk about is HCC screening. So Dawn mentioned earlier, we have to understand where in the progression of fibrosis these patients are when we're first assessing them. Of course, all of our patients who are cirrhotic, they need HCC screening using ultrasonography, alpha fetoprotein levels every 6 months. But there are also some other high-risk groups that the AASLD guidelines specify more frequent screening, specifically patients who don't have cirrhosis, but other risk factors. And I know, Dawn, you were mentioning to me earlier, you're seeing in clinical practice a lot of non-cirrhotic patients who don't even necessarily fit in these parameters that AASLD discuss. You're screening them more frequently for HCC.
Yeah. So The guidelines as far as the group, so Asian, particularly Asian born, immigrated to the US, and same thing with African. The guidelines are there that for men at the age of 40, you start screening, for women at the age of 50, regardless of degree of fibrosis. And part of that is because in those areas, it's likely that they have had hepatitis B since childhood. So they're more likely over time that's when they're going to start seeing HCC, where most persons in the US that have hepatitis B were likely exposed a little bit later in life. So I think that's part of why the difference is there. But we don't always know when our patients were exposed. And ultrasound is simple, it's fairly inexpensive. It helps us to keep an eye on the morphology of the liver. And, when we see something there, then we can act on it versus I think sometimes we've all been burnt where we have that one patient that, they haven't ever had screening and they're coming to us for the first time, even though they've had disease for 2, 3, 4 years. And we unfortunately find something bad that if we would have just kind of been on it initially and screening them, even if you do it once a year versus twice a year, if you're kind of on the fence about what to do. And that's where taking the guidelines and actually applying it and integrating it into practice can be a little bit different. It's not like baking a cake where you have to follow a recipe for the most part, like ingredient by ingredient, but sometimes you need to add a little something or take something away in order to best meet the needs of the patient.
Yeah. And more, I mean, for me, and I'm assuming for you too, Dawn, this isn't necessarily something that's even just specific to chronic hepatitis B. All different chronic liver diseases these days, we're seeing earlier emergence of HCC, whether it be, other viral hepatitis, hepatitis C, steatotic liver disease. In hepatology practice, like Dawn said, the cost of screening for these things is relatively low. But if we find it early enough, we can massively change the trajectory of a patient's life. And in chronic hepatitis B, we know that's the number one etiology of HCC worldwide. So it's a well-defined risk factor. So if there's another big takeaway is screen for HCC early and often if you have access to it.
And even screening for hepatitis B, the new guidelines say everybody over 18 should be screened at least once. So hopefully we'll capture patients earlier.
Exactly.
Treatment-wise, so 3 options, primary mainstays for treatment. Entecavir, which has been around for quite a while. And then we have tenofovir, which there's actually 2 tenofovirs now. There's tenofovir DF, which is never mind, I'm not even going to try. And then there's tenofovir AF. And they're very similar drugs. The difference is the carrier molecule that comes with it. So it's, when I think about treatment and which treatment I'm going to start on patients, we know all 3 of these drugs are very efficacious. I'm looking at cost. I'm looking at insurance coverage. And also to some degree looking at the individual patient, which is when it comes into, to some degree, patient-specific different risk populations. So patients with renal disease, patients that are pregnant. Scott, do you want to elaborate on that a little bit?
Yeah. So pregnancy, just to backtrack, I agree with Dawn that the best medication for a patient is the one they're going to take, that's going to be available to them. So all these are great options and you have choice there depending on the patient. When it comes specifically to something like pregnancy, chronic hepatitis B and pregnancy is a very broad topic that, we could easily have an hour-long talk on. But when it comes to specifically these treatments, if a patient is on treatment already, once they become pregnant, the question is, are we continuing treatment? If they are just recently diagnosed with chronic hepatitis B while they are pregnant, on their perinatal workup, the question is, when do we initiate treatment? Oftentimes, if the patient is on board, it's going to be 3rd trimester. And when it comes to picking medication, generally speaking, the the preference in practice is TDF, the tenofovir DF. If a patient is on entecavir or some other older generation of medication, the recommendation is generally to switch them to TDF. I haven't in practice used TAF in pregnant patients because there is limited data available on the safety of it. But from what we know at this point, it is safe in pregnancy. It's just not kind of well validated in the literature. So mainstay of treatment in pregnant patients is the tenofovir based regimen. Did you mention renal patients also, Dawn?
Yes. So renal patients, which is interesting, and this is where you have to adapt guidelines to practice. The guidelines have not fully updated as far as renal. So traditionally, entecavir was the drug of choice for patients with renal impairment and on dialysis. Entecavir can get a little bit tricky with dosing when somebody is on dialysis. TDF, not okay for patients with renal disease. But again, it's, the right drug for the right patient, and the patient that we want the patients to take their meds. And sometimes if we make that very challenging and difficult and complicated, then we may see less adherence.
Yeah. I mean, and especially going back to pregnancy, when we're working with pregnant patients with chronic hepatitis B, of course, the patient themselves is important. Are they going to have a hepatitis flare? What's this going to do to their long-term, liver disease and their outcome? But also the baby that's on the way. Their outcome is also really important. So, whether you're talking about a patient who's pregnant, a patient who is on hemodialysis, I find that utilizing, what the patient wants and what the patient needs, as well as the patient's other care providers, maternal fetal medicine, patients are likely to be linked with a provider like that if they're pregnant with chronic hepatitis B, and making sure you're on the same page with kind of all parties to prevent any lapses in treatment, prevent any contradicting, guidance or treatment recommendations. So overall, when it comes to viral hepatitis, chronic hepatitis B, getting everyone involved is really important for patient outcomes, and we see that in practice every day.
So I think we're just about out of time. I know Scott and I could probably spend hours upon hours talking about liver disease and hepatitis B, but main things to remember is there are guidelines, and guidelines are great to be able to refer to. AASLD treatment guidelines are available on their website. And as far as the newer simplified guidelines, they can be found online. They're just not included from any of the societies just yet.
Yeah. And again, end of the day, there's lots of great treatment options for patients. Include them in your decision making. And yeah, thanks for joining us.
So much.
For more information, you can go to the GAP website, AASLD guidelines. There's a wealth of information out there. So thanks again, Dawn.
Yep. Thank you, Scott. And thanks, GAP, for having us to talk about this important topic.